everyone, my name is Emily Heath. My first case study presentation will be on the problem behavior of noncompliance. I created a visual overview of the presentation as you can see on the screen. I will start by briefly introducing my client and the problem behavior or target behavior of interest. I then broke down the assessment method and the data-informed hypothesized maintaining contingencies. The intervention strategy is broken into 3 sections: antecedent modifications, DRA, and visual aids, to fully explain its components, which ties into the reinforcement schedule used. To conclude, I will explain the strategies used to promote maintenance and generalization before discussing the results. So my client is an 8-year-old male with an autism spectrum disorder, diagnosis being his only diagnosis. He has vocal and verbal communication skills that are nearly consistent with peers. His communication mainly lacks in sentence syntax and structure. He is highly reinforced by engagement with and praise from adults. However, he does not have the same initiation with same-aged peers. His biggest weakness as relating to the target behavior is his rigidity in social scenarios or changes in his routine. The problem behavior of interest is noncompliance. It is defined as any instance in which the client refuses to or fails to follow instructions, requests, or rules within 3 seconds given by caregivers, teachers, or therapists through verbal protest, physical resistance, defiance, or ignoring. In the parentheses, you can see some examples of topography of each form. So noncompliance most often occurs during non-preferred tasks, especially academic tasks and work, in addition to changes in routine and unwanted or non-preferred transitions. The magnitude of the behavior does vary, so low intensity usually includes verbal protest, defiance, and/or ignoring the requester. High intensity noncompliance includes behaviors that could be harmful to himself or others, so this includes physical resistance and aggression, property destruction, and/or stripping or urination. A functional behavior assessment was used to identify the function of the problem behavior in order to determine why it occurs and what a functionally equivalent replacement behavior could be or would look like. So the first step was doing a caregiver interview to collect information from his mother regarding the behavior outside of the clinic in other natural settings like school and at home. ABC data was then collected by observing him and descriptively recording what occurred antecedent or before the behavior, which is A, then the topography of the behavior, so B, behavior, and the consequence, C, of the behavior. These 2 forms of data collection aided the development of a hypothesis about the maintaining function. The intervention was then developed, data collection occurred to track the intervention's effectiveness, and maintenance and generalization techniques were implemented from there. The hypothesized maintaining contingency was socially mediated escape from demand. Socially mediated just means that another person had to act in order to allow the function to take place. So when engaging in non-compliant behavior, the client was able to avoid or escape an undesirable activity, which negatively reinforced the problem behavior. So allowing him to escape the demand strengthens the probability of him engaging in the behavior in the future. The goal of the intervention was for the client to comply with demands given by at least 3 therapists, so strictly in a clinical setting, 80% of the time without engaging in any form of noncompliant behavior. The first leg of the intervention is antecedent manipulation. So this is implemented prior to and independent of the target behavior's occurrence by making various environmental modifications. Some of these included reducing distractions during academic tasks, adjusting task difficulty to empower him to finish a task without feeling overwhelmed, increasing time between demands rather than continuously piling them on, and remaining consistent with demands instead of creating a confusing environment or removing the demand altogether. Differential reinforcement of alternative behaviors, or DRA, is the second leg. So this involves reinforcing a desired alternative behavior while withholding reinforcement for the problem behavior. So the alternative behavior in this case is compliance with demand. This is defined as the client following given instructions or complying with requests within 3 seconds of delivery without engaging in non-compliant behaviors. So DRA uses a concurrent schedule of reinforcement. That means that the alternative behavior is put on a dense schedule of high quality reinforcement at the same time that the problem behavior is put on extinction, or a very lean schedule of reinforcement. Compliance is reinforced through positive reinforcement, meaning rewards or incentives are provided following compliant behavior. So it started on a fixed ratio schedule for every response, or FR1 continuous schedule. And that was faded to a more intermittent schedule as data reflected that compliance was increasing. In naturalistic settings, praise from a caregiver was used as the primary reinforcer, and that was often paired with an excited tone and or high five, for example. And then during academic or table work, a token board was used for steps of work completed without engaging in non-compliant behaviors. So the token board, he would earn 1 token each time he completed one of the steps of the task. And then when he completed the token board, he could exchange those tokens for his reinforcer, his backup reinforcer. Although he did earn a preferred activity or reinforcing object, he did not earn the most reinforcing reinforcer. So a deprivation strategy was used by withholding access to the most preferred reinforcer until the end of the entire session. If the client engaged in compliant behavior at least 80% of opportunities, access to that most preferred activity was then given. Extinction was used for non-compliant behavior by withholding all reinforcement and avoiding giving attention to the target behavior or any of its topographies. So the caregiver was instructed to remain calm in body language and tone while holding the original demand in place. The final component of the intervention plan was using visual aids. So the client was given a visual schedule during school specifically that allowed him to predict what was coming up next in his day. Then during therapy and at home, first then boards were implemented to identify what the current task or demand was visually, and then give him the choice of various reinforcers for completion to add as a visual under that then column. So this uses what's called the Premack principle. First, we do this work, then we earn this video game. Least to most prompting was used to aid the client increase independence with demand completion. Most often, in this case, verbal prompts or gestures were the only form of prompting required. But this was basically implemented to help the client understand and follow given instructions, as well as decrease the maladaptive behavior should he become frustrated with a given task. To collect data, a frequency count was taken for each occurrence of compliance and each occurrence of non-compliance. The data was graphed to analyze and evaluate the effectiveness of the intervention over the treatment period, and it also allowed for a visual representation of progress to determine if adjustments were necessary at any given point. On the left side, you can see there are these images of 2 clickers. So basically, every single time compliant behavior occurred or non-compliant behavior occurred, one was clicked, and then a percentage was calculated between the two in order to come up with that 80% necessary to earn the most preferred reinforcer at the end of the session. Then, to promote maintenance of progress, just as discussed, data was consistently reviewed and strategies were modified as necessary within the intervention plan. And then, generalization methods included collaborating with the client's additional caregivers in his daily life, so teachers, other therapists, parents, as well as training them on the intervention and reinforcement techniques used in the clinical setting. And this helped provide consistent treatment across all settings that the client may encounter. So then once the alternative behavior was consistently displayed, frequency of reinforcement was faded, as were the uses of the visual aids. So two limitations of the intervention in this case included the client's rigidity to responding to the demands given by any individual who was not deemed his therapist or his person to listen to at that given moment. And the second was accepting changes in routine not reflected by the visual schedule. However, overall, the client responded very well to treatment and did meet that initial goal.